Learn from the masters. For today's session, we'll have a session on eyelid reconstruction by Dr. Shikha, who was our consultant in oculoplasty and oculus oncology services at
cases which we get in our clinic, like this one in which there's an ectropion because of psychiatric secondary to trauma. It can be sometimes secondary to burns. There can be cases of coloboma leading to exposure keratopathy and further requiring some sort of intervention in kids. It can be congenital as well as traumatic. Then another set wherein entire oncology comes in, where all the eyelid malignancy lesions leading to eyelid defects post-excision biopsy, and another set post-trauma, day-to-day post-RTA, where we should have a basic knowledge of eyelid flaps and grafts in order to do a perfect repair. Now, always the primary aim in case of an eyelid reconstruction is always to restore the protective function of the eyelid first, and the vision, and then cosmesis comes. We cannot, no matter what, we cannot put the protective function at stake for cosmesis. Whenever we look at eyelid, we should always have a mental picture in which Dr. Saptagirish, am I audible?
Yes, you're audible.
Because I'm getting messages that I'm not.
No, it's okay. You're audible. You're nice.
Okay. So whenever we look at an eyelid, we should have a mental picture of dividing it into two lamella. One is anterior lamina and one is posterior lamina. Anterior lamina consists of skin and orbicularis tissue, and posterior lamina consisting of tarsus, the retractors, and the conjunctiva. So whenever we look at eyelid, first just look at these two. Okay, anterior lamina is involved, or posterior lamina is involved, or both are involved, and then go ahead with further planning. Another concept which we should have before we go ahead with all the discussion is something known as relaxed and tension lines. So what is RSTL? RSTL is basically orientation of the collagen fibers, and which are basically the wrinkles in an aging skin, all the lines and wrinkles. Why we should know about it is because we should try to orient our wounds parallel to these RSTLs so that the scar formation is minimal. What happens is there's something known as line of maximal extensibility. What is that? Is basically the extension, the increase in lengthening of the skin under pressure. So this line of extensibility lies perpendicular to RSTL. So whenever a wound is healing, so maximum wound tension should lie parallel to LME or perpendicular to RSTL. So in order to give that, we should have a wound parallel to RSTL so that the wound tension comes parallel to LME. So all these eventually leads to less scar formation, which is a very important factor when we are dealing with facial tissue. So when we look at the periocular tissue, this is how the orientation of the wound should be ideally. Now again, there's a thing over here. When we look at the lid margin, the wound is not parallel to RSTL, it's actually perpendicular to RSTL. Now reason being why? If we make it parallel to RSTL, that is parallel to lid margin, what will happen is the wound will, while scarring, will sort of pull down the eyelid and cause lag of thymus and further eyelid malpositions, which we don't want. So that is why whenever we are orienting a wound, in cases of lid margins, near lid margins should lie perpendicular. The rest according to the RSTL as we have seen. Now, what are the basic principles when we go ahead with the surgical procedure? So whenever you're planning a surgery, these are certain points which is like a checklist. You should have a mental picture of these points. Okay, what is the horizontal extent of the defect, whether it's involving 10%, 20%, or whatever percent of the entire length of the eyelid margin, whether the median and lateral canthal tendon are involved or not, because the moment they are involved, we have to change a plan. How is the periocular tissue? Is it viable? Can we use that for forming flaps and grafts? What is the vital status of the fellow eye? Is the patient one-eyed? Is it not? What is the age? Because with aging, redundancy of the skin is increased. So you can actually use it for formation of flaps more easily. And obviously the surgeon's expertise comes into the picture. So this is like a mental checklist. So whenever we look at a lesion, these are the points which we need to make a check. Okay, this is the situation, and then plan further. So, as I discussed earlier, whenever we look at the lesion, look whether the anterior lamellar defect is there, or a full thickness defect is there, or posterior lamellar defect is there. For example, if it's only anterior lamellar, that means only the skin or orbicularis is affected. In that situation, how do we go about with the management? For that, we need to suppose for if the lesion is very small, it is less than 1 centimeter, we can just leave it to heal by granulation or secondary intention. That's something known as Lasser's fair also. Why? Because it actually heals very well without scarring, and we do not need to do any repair. Whereas the lesion is bigger, we can go ahead with primary closure, or we can use undermining, and we can use flaps and grafts. In case of a full thickness defect, again, there's a vast set of flaps and grafts which we'll be discussing further. So another thing is, as I had told you, how much is the extent of the lesion. So suppose the defect is less than 1/3. In that situation, we can actually go ahead with primary closure with or without lateral canthotomy. So once we do a canthotomy or cantholysis, that gives us that extra 3 to 5 mm of tissue to play around with. If it is 1/3 to 50%, another very good option which we actually can use is Ten-zells flap. That also gives us nice amount of tissue for reconstruction. And when it is more than 50% or to almost 100%, then we have vast amount like bridge conjunctival flaps. We have free tarsoconjunctival flaps. We have all the rotational flaps, cheek rotational flaps, which can work. So what are the rules? Again, as I told you, if it's a small skin defect, we can go ahead with a direct closure. If it is not possible, direct closure is not possible, we need to do canthotomy and cantholysis. If that is also not sufficient, go ahead with a flap or a graft. One lamella has to be, only one lamella can be corrected with a free graft. You cannot put a graft over a graft. Graft can be placed over a flap over a flap is possible. But graft over a graft is not possible because graft is an avascular structure. It derives its nourishment and vascularity from the recipient bed. So we need to have a vascularized base for a graft to survive on. So let's first discuss skin grafts. Whenever there's an anterior lamellar defect, we can do a skin graft. As I discussed earlier also, skin graft is basically, it does not have much of vascularity of its own. It's not like it's completely avascular, but it derives its nourishment from the recipient bed. So in that situation, you cannot place it over an avascular structure like bone, cartilage, or tendon. You should have a nice healthy base to put a graft on. The common sites for skin grafting in periocular areas are the best graft can be obtained from the other eyelid because that's the best color match, best texture match. Apart from that, we can take from preauricular area, postauricular area, supraclavicular area, axillary area. These are common sites from where we actually take tissue for reconstruction in eyelid area. So there are various stages of graft uptake. When we talk about how a graft survives, when it is not a vascular structure, how does it survive? So first 24 to 48 hours, there's a process known as imbibition, in which the graft is being held up by imbibition, and that is, it prevents the desiccation of the graft in this period. It derives its nutrition by imbibition from the base, from the bed. After that, there are small capillary buds seen in the fibrin layer between the graft and the recipient bed. This is the period of inosculation or capillary ingrowth. And around 4 to 8 days, the revascularization eventually restores, wherein there occurs anastomosis between the capillaries of the graft and the recipient area, and they form the entire channel. That's when the graft starts turning pink and warm. That's when we see that the graft is actually pink in color. That's why when we are doing follow-up of the patient, we need to check whether the graft is pink or not. Is it cyanotic? If it's cyanotic, that means the anastomosis has not occurred properly. Another thing which we will see would be actually the thickening of the graft also around this area, because there would be a lot of edema, there would be microvascular vasoactive substance being released. There can be deformation of the epithelium, and there can be hypopigmentation of the graft at that particular time, which can be seen, which eventually restores. It takes almost 6 weeks for the entire collagen to turn over. That means to get replaced by the fresh one. And that is when the graft is completely taken up. It almost takes more than 1 year for nerve endings to grow there and for the sensation to return, almost 1 to 2 years sometimes around that area. So this is an example where he's a 5-year-old child who had thermal burns, and because of that, there was there was ectropion of the lower lid as well as lag of thalmus, as we can see very clearly. So in this situation, we did a skin graft, and the graft was harvested from the postauricular area. Now it's a basic simple technique. What we need to do is take a subsidiary incision. What is important is to take the incision along the entire length of the eyelid, not at the involved region. We do not take incision till here. We have to take the incision along the entire length and then try and excise all the cicatrix bands in the suborbicularis plane. Again, we don't have to go full thickness so that the base is created. We just have to go subdermal and suborbicularis maximum so that we have a nice healthy base on which the graft can rest. Another important point at this point is the base should always be free of any sort of hematoma or debris. The recipient bed should be free of hematoma or debris. Otherwise, when we are going to suture the graft, it will inhibit the imbibition process and the graft will not be taken up. Again, there would be higher chances of graft failure. Fourthly, whenever the entire defect has been created, we make a template. Now the template, what we make, whatever measurements we take, we need to add some extra 15 to 20% when we are harvesting the graft. Why? Because in case of full thickness skin grafting, there would be almost somewhere between 20 to 40% of elastic recoil, which is known as primary contraction of the graft. So once you excise the graft and you try to place it over the bed, we might sometimes feel that the graft is insufficient in size. So in that situation, you should add some extra 15 to 20% so that it can be taken care of. The elastic recoil is taken care of. Sometimes when still the graft is inadequate, we can go ahead with meshing. So we make these slits along the entire graft and pull it. So it forms meshing. It's like meshing. So that increases the size of the graft and again, it can be taken up. We have used 6-proline in this. Usually we take proline only for the suturing. So this is how we suture eventually. We remove the bandage almost around 48 hours later so that it rests. Another important point is we should do tarsography. When we are, especially in these ectropion corrections, we should first do tarsography and then place the graft because that increases the immobility of the graft. The idea is the graft should remain immobile for as long as we can keep it. This is post-op picture 1 week. Not 1 week, sorry, 2 weeks, in which we've removed the sutures of the patient and graft is slightly edematous, as you can see, as well as it's slightly hypopigmented because of the deformation of the epithelium, and gradually the turnover will take place and melanocytes would form and the decoloration will go away. Lag of thalmus is completely taken care of in this situation. This is how it looks in the 2 weeks. Now coming to the posterior lamellar repair. So there can be various grafts for posterior lamina, best being tarsal graft obviously. Apart from that, we can use banked sclera, we can use auricular cartilage, we can use nasal septum. Tarsal graft, we obviously take it from the upper eyelid. So what do? Is we evert the eyelid over a Demers retractor and some 4 millimeter from the lid margin, we make a horizontal incision in the tarsus and taking care not to damage any other structure. Skin is not to be damaged in this. It's not a full thickness one, just a tarsal incision and extend it vertically up to the upper border of tarsus. We try to take some 1 to 2 mm of conjunctiva superiorly because it helps us in forming the lid margin eventually. So this is how we excise the entire tarsal plate en bloc and then we suture it with vicryl sutures, and the conjunctiva is wrapped around the lid margin over here, so it gives a smoother surface. Now coming to flaps, what exactly is a flap? So flap is a local cutaneous flap, is an area of skin and subcutaneous tissue which has a direct vascular supply. A, it should have a vascular supply. B, it is usually adjacent to the site of a lesion or a defect. Now, classification, there are n number of classification for flaps. Based on the location, it can be either local or distant. It can be based on blood supply, which can be random or axial. Axial one has a specific direct cutaneous artery to it. Example being common being paramedian forehead flaps, which we use. So, and that's supratrochlear artery is the supply. Random pattern has subdermal vascular plexus to it. So that is the supply to it. According to the types, again, we can see rotational flaps, we can see transpositional flaps, we do have further advancement flaps. So what happens in rotational flaps? So rotational flap, they're all pivoted flaps. That means they are joined at the base, they have a pivot to it. And then we rotate it along a semicircular arc. So for example, here's the defect. And this is our flap which we have created, and we're going to rotate it in suture over here. So as a result, we are going to have tension around this area. This is the tension area. Now there's something known as transpositional flaps. Now what is a transpositional flap? Instead of rotating it around an arc, we are going to rotate it in a vertical manner. It has a linear axis to it. That is what is a transpositional flap. So in this particular situation, we're going to flip it around over here. This is the defect and suture it. And this would be the tension line eventually. So this is the area of maximum tension in this situation. This is transpositional flap. Next is advancement flap, which is very commonly, we all unknowingly use it basically. But in this particular situation, unknowingly we all use. So whenever we are doing direct suturing, we tend to feel that slight undermining is required, and then we slide it on and then suture a skin or orbicularis tissue. That is what is actually an advancement flap. This is what we do in advancement. We sort of undermine the tissue and just slide it across and suture. So this is what is an advancement flap. Next is based on composition. It can be cutaneous, muscular, mucosal, any of these, whatever the composition is named accordingly. Now, what are the benefits of flaps? We tend to choose more flaps more often than the grafts. The reason being obviously because it has its own vascular supply, so the uptake is better, color, texture, match would be better, near normal innervation would be there, so cosmetic results would be better. That is the reason why we kind of choose flaps over grafts. Now let's start discussing examples. There are going to be a few stuff which is from Dr. Milan Nayak, who has been my mentor during fellowship, and I've shared certain his images also. When we look at this lesion, eventually there's this lesion, and as we can see, he's taking clear margins. What we need to do is any wound converted into a pentagonal fashion. Whenever we are dealing with lid margin, the best cosmetic results comes when it is in a pentagonal fashion. The vertical limb of the pentagon should always lay perpendicular to the eyelid margin, and it should extend up till the entire extent of the tarsal plate. It should not end till here. It should go up till the entire extent of tarsal plate. That is rule number one. And then we convert it into a pentagon. So this is what we have done over here. Now let's go back to that mental picture. I had told you we have to tick mark certain things. A, what is the length? How much is the tissue involved? Is it less than 30, 1/3? Is it 1/3 to half of the lid? So when we look, it looks like 30 to 40%. So we can try maybe a direct repair in this particular case. Another thing, the periocular tissue is viable. The canthi are not involved, so we don't have to worry. So in this is like a good case for a direct repair when we look at it. So this we have already done, and then we try and approximate the edges of the wound and see if there's any sort of tension. Because if we suture under tension, what will we do? It will be a tight eyelid. There are chances of eyelid retraction. There are chances of lag of thalamus, which we don't want. So eventually, this is what we realize, that it's slightly tight around here. So we are going to make a snip around the lateral canthus and do canthotomy, so that it gives that extra 3 to 5 mm as I have discussed for us to play around and actually suture the wound. So this is how we do. Now for lid margin, we do vertical mattress suture, and mostly we use 6/0 silk around here. So this is what we do. And whenever we are taking suture, another important thing is go perpendicular to the lid margin. Do not slant your lid, otherwise it's going to be partial thickness. It's going to be uneven, and patient will end up with a notch. So go perpendicular to it, go full thickness, Another important thing which really helps us, this is what we have learned in our fellowship, is count the meibomian glands around the wound edge. So count them, four on both sides, two on both sides. This kind of gives us an idea. Yes, we are equidistant on both sides. So this is what we have done over here. So around, when we first want to prepare the posterior, then the middle lamina, then the gray line, and then the anterior lamina. This is how you always do a lid margin reconstruction. So posterior to the fourth meibomian gland on one side, counted, pass the needle perpendicular to it, full thickness into the tarsus, equidistant on the other end of the edge of the wound, and take it out from the fourth meibomian gland again. Not exactly the fourth meibomian gland, I mean posterior to the fourth meibomian gland. Then go to the second one from the wound edge. Go behind it, take it out, and same way on the other side. So this sort of gives you equidistant idea. It can be 2-2-1-1, it can be 4-4-2-2, it's up to you. But these two can be easily worked around, and that's how you should suture it. This is how you take the vertical mattress suture. Another thing important is, since we are dealing something which is so close to the cornea, the lid margin, the suture can rub against the cornea. So we can leave the cut ends long and further sort of imbricate it with the skin wound sutures. This we can do. Another thing is, keep it very short so that it doesn't rub. Whichever, the idea is it should not rub against the cornea. And when you imbricate the long ends, when we are taking the skin wound suture, first tie the knot of the skin wound and then imbricate the long ends. Because if you imbricate and then take the first knot, we sort of embedding those sutures into the wound line, which we don't want, and it will hamper the wound healing further. It will just get embedded over there in the skin, which we don't want. So this is how we go ahead, and in the end, this is how it looks. So first take the tarsal plate sutures, do the orbicularis suturing, skin suturing, and imbricate the long ends. See, this is how we do. So what can be the complications of direct repair? Obviously, lid notching, if it doesn't, the vertical limb of the pentagon is not at the entire length of the tarsus. Second is when we do not, another important thing, when we tie the suture, I forgot to tell, whenever we tie the suture, we sort of leave a slight pucker at the upper lid. It should not be flat. One can see that there's a slight bulging, this slight puckering of the lid margin. This is the ultimate aim. The reason being, why? Because once the scarring occurs, it sort of flattens down. So we don't want that happening and further giving us a notch. So eventually, leave it slightly overcorrected so that when the scarring occurs after 6 weeks or 2 months, it's completely leveled out. Second is, in case of upper lid, whenever the suture is far too tight, as it can cause ptosis. In case of lower lid, it can cause retraction and lack of thymus. Sometimes when it is not aligned correctly, that means anterior lamella to the anterior lamella, posterior lamella to the posterior lamella, it can lead to trichiasis, malpositioned eyelids as well. So next we come to lateral canthotomy and cantholysis. As we have discussed, that it gives us some extra margin to repair the tissue. The first thing what we do in lateral canthotomy is, we know that the lateral canthal tendon is in the shape of a Y. Okay? So first thing what we do is we split the lateral canthal. We go in with the Westcott scissors and cut it. So we are splitting the vertical limb, the horizontal limb of the Y. Sorry. So this is canthotomy. When we say cantholysis, we are actually cutting the crus, one of the crus of the lateral canthal tendon, superior or the inferior crus of the lateral canthal tendon. Further, once we have split it open, then we do cantholysis. We go cut the canthus with the Westcott scissors. This is how we go. We go with subconjunctivally and we cut it off. We snip it off. So once it snips off, actually when the tendon is cut, we can actually feel sudden release in the tarsus, and that's when we know that we have cut the canthus. Sometimes when you can visualize. If you can't, you actually feel the release in the tightness. Sudden release will occur. So this is lateral cantholysis. Now let's discuss some examples. When we come to, so this is a 6-year-old child again who has come to us, who has a clear upper lid coloboma, and also it's causing exposure keratopathy. Child also has dermoid and it needs vision restoration as well. So when patient comes to us, how again, let's go back to that checklist. How much is the defect? It's almost 40 to 50% of the upper eyelid. Canthi are not involved. We know that. Vision, definitely patient needs for vision restoration. Patient would need further surgeries as well. Young child skin is healthy, otherwise everything is healthy. So our plan is to go ahead. So what we did was Ten-zells for this child. Now there are n number of ways how you can do reconstruction. There's no one simple one way out to it. It depends from person to person, and you really have to change your plan according to every single child. Now this was a child who needs further surgeries. We would want to give him do a repair which is like a one-shot surgery. We don't want him to undergo GA again and again unnecessarily. So this was the reason why we took for Ten-zells. 50% can easily go ahead, as I had discussed earlier. And this is the post-op result in which we can see the coloboma has been repaired and now the cornea team can further intervene. Now let's discuss the steps of Ten-zells flap. How do we do a Ten-zells flap? So whenever, whatever defect it is in a lid, this was a case of upper eyelid, we converted into a pentagonal defect. Next step is we need to create a flap. So first step is draw a semicircular arc extending from the lateral canthus up till the brow line, almost up till 2 centimeters. This is what we do, and create it into a flap. Okay. Next step is we do a superior cantholysis. Okay, this gives us, again, everything is loosened up, we can suture over here. In this particular situation, what they had told in the book, it's written that sometimes there's a conjunctival defect which is formed. There's a large conjunctival defect which is formed. So in order to treat that, what we do is we one second, sorry. So we can take a mucous membrane graft and suture over there in order to replace the conjunctival defect. And then further go ahead with direct repair, and then so this is how you do the direct repair. Slide it down, do the direct repair, and do a repair over here in the end. This is how it looks. So this is what is how we do a Ten-zells flap. Basically, it is a combination of both, of direct repair, cantholysis, and we create a flap around the lateral canthus. Now this is another interesting example. So there's this patient who comes to us post-trauma. He had an upper eyelid defect, and because of that, the patient had an upper eyelid coloboma. When we look at the upper eyelid, we can actually see, again, let's go through that chart. Almost the entire eyelid is involved, but luckily the canthus is not involved. Both sides the canthus is okay. And when we look at the periocular tissue, it's healthy, viable, young patient, and vision in both eyes good. So we decided to do a Cutler-Beard for him in this situation. Cutler-Beard was planned. So this is the video which I wanted to show. This is Dr. Milan Naik's video. Thanks to him that I have it. Okay, so the first step is always we give a local infiltration. We give adrenaline plus lignocaine, xylocaine mixture. First step is we split the lamellae, the upper lid lamellae, into anterior and posterior, and we try to freshen out the margins. Basically, because it's an old case, we need to remove all the debris, devascularized tissue, dead tissue from there, and split it into 2 layers, anterior and the posterior lamina. Whatever granulation tissue, thickened tissue was there, we have excised. Now we're going to create a flap. So how do we create a flap? Retract the lower eyelid and make an incision. It should be a full thickness blepharotomy, which you do. Make an incision 4 mm below the lower lid margin. So it is below the lower lid margin, and we are going ahead with full thickness. Care has to be taken not to damage the ocular structures in this point. So we do have a corneal shield around here. We can use a lid guard, whatever. Okay, so now we are splitting the lower lid lamellae also into anterior and posterior. So this is the skin. These are the lower lid retractors. and then extend the horizontal incision vertically up to the inferior fornix. Up to the entire depth of the fornix we are supposed to extend. Now what we are going to do is, 1 second, sorry. Yeah. So what we are doing is we are taking the posterior flap, what we have created. So we have split the lower lid flap into two, anterior and posterior. The posterior part we are going to suture to the posterior lamellae of the upper lid as well, so that we have retractor to retractor, orbicularis being sutured to orbicularis, skin being sutured to the skin. This is what we are doing. Basically, at this step, we need to be careful that we don't take full thickness suture. Otherwise, if the suture ends are rubbing against cornea, then we can land into trouble. So this is first step which we do. Next, we take out the skin as well underneath that bridge which we have formed, the lid margin. And then we suture the orbicularis to orbicularis and skin to skin. This is how it looks. In the end, post-op, this is how it was looking. This is post-op day 1. This is after stage 2. Now, what do we do in stage 2? We just go underneath that bridge and we just excise it. Some 2 mm below the actual lid margin, which we want the lower, like the upper eyelid lid margin, so 2 mm below that, so that you have that extra conjunctiva which can be rolled over the lid margin and the surface is smooth and it doesn't cause any abrasion onto the cornea. This is status post stage 2, post-op date 2 weeks. That's all. So what can be the complications? There can be upper eyelid ptosis occurring, corneal aberrations as I had discussed. There can be lower eyelid retraction. There can be persistent edema. Now, this edema, like in that situation, as we had seen, there's slight edema, but it tends to resolve as the time passes by. This is another interesting case. So there's this 19-year-old female who presents to our clinic who has a lower eyelid lesion in the left eye. It's a vascular lesion. And she had undergone some injectables, like she had been given injectables 3 times earlier somewhere else. We don't know which injections she has taken, but now she just wants to get rid of it because they tend to bleed sometimes. So she wanted a surgical intervention. So when we look at the lesion, most likely the differential was varicose. And when we look at the lesion clearly, that the skin is not involved, the skin is healthy. Again, let's do that mental picture. Involves almost 40% of the lower lid, a vascular lesion, mostly involving the posterior lamella, not the anterior lamella as such. Vision is good, periocular tissue is healthy, the canthi are normal, they are not involved. So we planned for Hughes in this case, Hughes flap in this case. We're trying to preserve the skin as much as possible so that that can be only used in, further to reconstruct the anterior lamella. So this is how we manage this case. So local infiltration was given and just near the subciliary incision was taken and the skin and orbicularis was dissected off the lesion, the tarsal plate. So this skin only works as a flap for us later on to reconstruct the anterior lamella. And then we en bloc excise the entire lesion, the tarsus. Sorry. I think the video has just stopped working. So the entire lesion is excised into. We measure the defect and then we plan the use. We will invert the eyelid, upper eyelid, give local infiltration around that area with subconjunctival space. And some 4 mm again, 4 mm from the upper eyelid margin. We excise it. And a horizontal incision is given some 4 mm from the lid margin. It is extended vertically towards the fornix. We have to make sure that it is in the subconjunctival plane. Mueller's muscles is not involved, because if the Mueller's gets involved, post stage 2, we can actually get upper eyelid retraction. So we try not to damage the Mueller's, stay as much as possible in the subconjunctival space so that our graft flap has only the tarsal, whatever tarsal length we have gotten, and the conjunctiva. After that, the flap is lifted down, and whatever remnant tarsal plate we have, we suture the flap tarsal plate with 6-0 vicryl. Again, care has to be taken that it is not a full thickness bite so that it doesn't irritate the cornea, eventually leading to further complications. The sutures have been taken with 6-0 vicryl over here. Pull the retractor, lower lid retractors up and down. And the skin which we had preserved in this case was actually used as a flap eventually, and then it helped us in replacing the anterior lamella. I'll just skip this part in order to save some time. Yeah. So this is post stage 2. Again, it's very similar to how we split open in Cutler-Beard. Similar procedure which we'll do is we place a butt inside underneath the flap and just inside. Take a full thickness incision. Try keeping some 2 mm extra above the lower lid margin so that the conjunctiva can be rolled out, as we can see in this picture very clearly. This is status post stage 2, post op day 1 week. And this is how it looks after 1.5 years. So what can be the complications? Again, as I discussed, lower eyelid retraction, ectropion whenever the anterior lamella is insufficient. So we should have nice anterior lamella. In this situation, we use the adjacent skin as a flap. We can also undermine further skin and use it further. We can also do a skin graft from the postauricular area or contralateral upper eyelid. We can use this skin graft also over in this situation. Since this underneath of the flap, we can place a graft also. And sometimes lower eyelid hypertrophy occurs. In that situation, patient might need some debulking also in future. Now, this is another interesting case. As we can see, this patient seems to have some malignant lesion. There is clear effacement of the lower lid meibomian glands. There is thickening of the lid margin. There is slight excoriation over here. There is loss of lashes. So it looks like a malignant lesion. So we need to take a 4 mm of clear margin. So this is what is marked. This was the amount to be excised. Yeah, so this is the amount of the eyelid to be excised. This is how it looks post excision. This was our defect. So let's again do that checklist. Almost entire lower eyelid is involved. Canthus is definitely involved. A part of upper eyelid is involved. Skin around this area is okay, we can use it. Now we have a we have three things to be replaced. A, lower lid posterior lamella. B, lower lid anterior lamella. C, the lateral canthus and the slight amount of upper eyelid. So what we had planned is, we had planned periosteal fixation for the lateral canthus. We had planned posterior lamellar replacement with hooks in lower lid. And we had planned a flap. It's a monopedicle flap from the upper eyelid itself over the lower eyelid, replacing the anterior lamella. So how is periosteal flap taken? So we expose the lateral orbital ring and take almost 8 mm to 1 centimeter thick band of periosteum. We make two parallel incisions and lift it off the lateral orbit. Sometimes when we think that it is inadequate, we can actually use the temporalis fascia as well. Now this periosteum would eventually be split into two, because the upper eyelid tarsus is also not there and the lower eyelid tarsus is not there. So we need to replace posterior lamella in both. This would be split into two and would be sutured to the remnant tarsus over here and the Hughes flap, which we will take for posterior lamellar replacement. So now next step would be, once we have lifted off the periosteum flap, next step would be to create Hughes flap. Once that is done, this is how Hughes flap look. This is our periosteal flap being sutured over here and to the remnant tarsus, the upper one. This is how it looks eventually. Next step would be to manage the anterior lamellar defect. The monopedicle flap is being lifted off and sutured over here. This is how it looks. So this is how this case was managed. So we can use a lot of monopedicle flaps from the upper eyelid. Another very common one being from the suprabrow area, above the brow, which is known as Frick's flap. The benefit of it is it actually gives us a brow lift a bit of. So either you have to look at the patient and then decide, because in elderly it can lift because of the scarring. The brow would be lifted because of it causes imbalance between the two brow positions because of that. So that is another flap. Another monopedicle which you can actually take is from the nasojugal area. From the nasojugal area, just lift up the flap and you can use it for lower eyelid reconstruction. So there are n number of flaps like that, monopedicle, whatever area you can see. You can actually just follow certain rules. One of the rules is try maintaining 4:1 ratio of lenses to base, so that the vascularity is not compromised, as well as the dog ear formation is minimal in this situation. But 3:1 or 4:1 is the ratio which we usually follow for these long pedicle flaps. Another example is this one, in which we see again the entire lower eyelid is involved. It's a malignant lesion, because of obviously we can see that there's ulceration and all. Eventually, this is what we got the defect as. So again, let's do the same thing, mental picture. Lateral canthus involved, entire lower eyelid involved, anterior and posterior lamella involved. The depth of these defect, the anterior lamellar defect, is more than the previous one, as we can compare. And over here, the medial canthus seems to be normal to me. Let's go ahead how we reconstructed this one. So again, the same thing we followed. Again, the periosteal flap was taken. Similar process. Similarly, we did a Hughes for it, but instead of doing a monopedicle flap from the upper lid, we actually did, because we needed more amount of skin, we took a forehead flap. A median forehead flap was taken and it was transposed over here. Now this flap needs to be operated in 2 stages, because you can actually see there's this bulging of tissue and dog ear. This, after 2 to 3 weeks, we are going to excise. This is Hughes flap being excised, and this is how the bridge flap is being excised, and end result is this. So this is how we manage all these cases. We can always take nasojugal fold flap, we can take paramedian forehead flap. Especially medial canthus repair can be done with rhomboid, lamellar flaps. There are n number of flaps. It's just that we need to think. Canthus is involved, posterior lamella is involved, anterior lamella is involved, and go ahead accordingly. In the end, I would just like to summarize with one point that always no graft over a graft. Graft, flap, flap, flap can be done. And just follow simple rule. Posterior lamella is involved, you have to replace posterior lamella somehow. Anterior lamella is involved, anterior lamella has to be replaced. That's it. Once you know all that, then you will start creating different combinations, perturbations, and then go ahead with the reconstructions. Over to you, Dr. Saptagirish. If there are any questions, I would love to answer.
Thank you very much, Dr. Shikha. It's been a very nice talk, very comprehensive, and you covered almost all the aspects of lid reconstruction, also advanced reconstructions. We'll just see if there's any questions from anybody. There's a question from Dr. Rahul. He's saying, what should be the ideal suture material for lid surgery?
So for eyelid surgery, depending, if it is a posterior lamellar suture, which we need to bury, we use 6-0 vicryl. If it's a lid margin, we tend to use silk because it stays longer, because we would want the suture to stay for almost 2 weeks for the healing to completely occur. And for anterior lamella, we can use 6-0 vicryl. We can use proline also, depending on if it is, if we don't want it for longer duration, we can use proline as well.
Right.
Does that answer your question, Dr. Rahul?
Yes, usually the thing is that when you're closing mucosa to mucosa, you want to use an absorbable suture. Well, now you can use catgut, but for the lamella where you want to retain the sutures for much longer, like the skin, you'd want to use a non-absorbable suture. But the other thing is that even with vicryl, you can close the skin also, because we tend to remove the sutures much earlier before the vicryl gets absorbed or before it loses the tensile strength. Dr. Sri Ramcharan has a question. He says, how to manage the orbital fat prolapse during surgery?
Orbital fat prolapse, as in when the lesion is really deep, I mean, is what you're trying to say?
Yes.
So in that, just place it back and go ahead with the suturing. You don't have to touch it, because the moment you start cutting around the fat, you'll start bleeding and you will start losing your planes. So the best is to not to touch it and just go ahead with the suturing according to the planes. That is what I can understand what you're asking.
Okay. Dr. Kulkarni Samitinja is asking how to manage a graft failure.
Okay, in that situation, if the graft, initially just wait with antibiotics. Eventually, when it gets contracted, we have to use, do the resurgery in the end. If it is actually failed, if it is in the beginning, do a lot of try doing compressions so that it gets it stays at the near the bed.
Dr. Sirisha Polkam is asking, is the periosteal flap a pedicle flap or a free flap?
So periosteal flap is a pedicle flap because you have to keep it attached at one end of the orbital rim, the lateral orbital rim. So you just lift it off and cut it. If you need it for both upper lid and lower lid, you cut it in between and then suture it to remnant tarsus on both sides. Or if suppose a one lid, so just place it. Don't cut it off, otherwise it will not work. You need to keep it attached at one end.
And Dr. Seema is asking, what are the cutting cautery parameters used for lid surgery?
So it depends on which cautery we are using. Elman has different, this is all radio frequency cautery which has been used. And all of them, we have different settings. Currently I'm using Tentamid, so I keep it around 4. in cutting mode and 4 to 6 in cutting mode. So every machine would be different. You have to look at it accordingly. Because initially when I was using Elmin, I had different settings at that time.
Right. One small trick is that when you start using a cutting cautery, you may have to titrate the burn according to your machine. So because each machine has its own settings, and what sounds 4 in one machine may not be a 4 in another machine. It's to understand how it cuts and that and you don't have a collateral charring. That's how you know that you're actually using the cutting to its optimal level. Dr. Arpita is asking, after reconstructing lid for malignant lesions, if the margins become positive, how to proceed further?
So mostly all the eyelid surgeries, the preferable mode is that you have to do frozen section. And best is if you don't have a frozen section, for immediate results in your own institute or where your hospital where you're working, so you can actually patch the eye for 1 or 2 days and wait for the result to come. And if it comes out to be positive, take another set of margins and then send it. This is how you work for malignant lesions. Sometimes it's a pagetoid spread. That means it is spread in conjunctiva. You can also do cryo at the margins so that it is dealt with. But you have to wait till the margins come out to be positive, negative.
Right. I don't see any other questions coming up. So yes, thank you very much, Dr. Shikha. There's a question from Dr. Debanshu. He's asking for defects involving the medial canthus and the medial part of the lower lid. How best to repair the defect and reattach the lower lid to reform the canthus?
So whenever the medial canthus is involved, you need to fixate the tarsus again to the similar periosteal fixation. What we have done on the lateral side, you need to do it on the medial side as well. But medial side is slightly tricky because you don't have to damage the lacrimal sac around that area. Already, if you're saying that the lid is involved, most likely the canalicula would already be damaged. So you have to lift up the periosteum and suture. And for the medial part of lower lid, you can do nasojugal fold, you can do rhomboid, you can do glabellar. These are the flaps which you can do. So it's basically along the nasojugal fold, you lift up a flap and suture it as a anterior, and posterior flap replacement or posterior lamellar replacement can be done with periosteal fixation flap. If you feel that the entire tarsus is involved, if the periosteal flap is not sufficient, you can also go with free tarso conjunctival graft, and over that you can place a flap. So there are a number of ways. The whole idea is you have to fixate the canthus, which you can do that with the periosteum. And if you feel that the periosteum is insufficient, you can go ahead with tarsoconjunctival grafts as well.
Right. Thank you very much, Dr. Shikha. It's been a wonderful talk, very comprehensive, and almost everything has been covered here. Thank you very much. And for tomorrow's session, we'll be having a discussion and presentation by Dr. J.K. Reddy, who is our consultant in cornea services and is also a mentor for most of us and a teacher to almost all of us. And he'll be talking on fungal corneal ulcers. Thank you very much, Dr. Shikha. Wonderful presentation.
Thank you.
And thank you all, and stay safe, and see you again tomorrow, same time, and the link also remains the same. Goodbye.